Welcome to the Deep Dive. We're here to take those really complex clinical subjects, kind of break them down, and give you the key info you need right at the bedside. Especially for you BSN nursing students heading into maternity and newborn rotations, think of this as your survival guide. Our mission today, it's all about spotting, stabilizing, and starting the management for the most common, but definitely high-stakes, complications you'll see in newborns. We're not just reading a list from a textbook. We want to get beyond that theory to, the practical stuff, the critical thinking you actually use. Because with newborns, waiting too long can have, well, lifelong impacts.
That's exactly right. It's that jump from the book to the bedside. As the maternity nurse, you really are the first responder for these high-risk babies. You might be on a mother-baby unit, maybe a well-baby nursery, but your assessment, your eyes, they're the front line. You've got to be sharp enough to spot the difference between normal newborn stuff, like maybe a slight temp dip or losing a bit of weight initially, and the things that are truly abnormal, the things that need action now, like jaundice showing up way too early, or breathing that keeps stopping, or those really subtle, almost hidden signs of infection.
Okay, so that's our focus, those key vulnerabilities.
Yeah.
We're going to dig into the risks tied to when the baby's born, gestational age. We'll cover breathing problems right after birth, metabolic issues like jaundice and babies of diabetic moms, infection control, and also prenatal drug exposure, specifically NAS. The goal is to equip you not just to see the problem, but to know those first few crucial steps to take before the specialists arrive, the NICU team, respiratory neonatology.
Exactly. It's about timely, smart nursing action, your ability to accurately assess and then clearly report changes, vitals, breathing effort, how they're feeding, their neurostatus. That's what defines expert care in this setting. It's a huge nursing responsibility.
All right, let's dive right in then, starting with maybe the most fundamental risk factor for any newborn when they actually arrive. Gestational age really sets the stage for the immediate challenges.
Yeah, so preterm birth, that's any baby born before 37 completed weeks. It's still the biggest reason for infant illness and, sadly, mortality worldwide. We've gotten much, much better at helping them survive thanks to NICUs, but the risk for complications, for long-term issues, it's still really high.
Yeah.
And it's directly tied to how early they are. #####A, preterm infants before 37 weeks.
So if you walk into a room, what are those immediate signs, those characteristics of a preterm infant that just scream vulnerability? How does that immaturity show up?
Well, their whole appearance kind of signals it. They often look quite frail, weak, not much muscle tone. They tend to lie flat, sort of extended, not curled up like a term baby. And their skin, it's incredibly delicate. It looks thin, almost translucent. You can sometimes even see the little blood vessels right underneath. They just don't have that layer of fat or the energy stores, the glycogen, needed for basic functions.
And system-wise, breathing is usually the top concern, right?
Yeah.
Especially for the really early preemies.
Yeah.
Why is that the first system to really struggle? And what does that look like for the nurse?
It comes down to lung maturity, specifically the lack of surfactant. Surfactant is this fatty substance lining the air sacs, the alveoli. It keeps them from collapsing when the baby breathes out. Without enough surfactant, those tiny air sacs collapse, and every single breath becomes a huge effort. That's what leads to respiratory distress syndrome, or RDS. At the bedside, you'll see those classic signs, grunting, that little noise they make trying to keep the air sacs open. You'll see retractions, the chest muscles pulling in with each breath, sometimes under the ribs or the sternum. Nasal flaring is common too. And just fast, shallow breathing. Apnea is another big one, those pauses in breathing, like 20 seconds or more. It's a critical sign that their brain and lungs are just getting exhausted.
Okay, so giving surfactant is often one of the first big interventions. What's the nurse's role in that? Sounds pretty intense.
Oh, it is. The nurse's role is absolutely vital. The surfactant goes right into the lungs through an ET tube, often in a couple of doses. We help position the baby, maybe turn them slightly side to side between doses so the medicine spreads out well in the lungs. And you have to watch their heart rate and oxygen levels like a hawk during the whole thing. The procedure itself and the fluid going in can sometimes cause their heart rate to drop or their O2 sats to dip. It needs really close monitoring and support.
You mentioned the lack of fat stores earlier, leading to temperature problems. We always hear about preventing hypothermia, being too cold, but you flagged hyperthermia, being too hot, as a hidden danger.
Yes, absolutely. Preterm babies just can't maintain what we call a neutral thermal environment, that perfect temperature range where they use the least energy without help. They lose heat incredibly fast, huge surface area compared to their weight, thin skin, no insulating fat, and they can't shiver effectively. But overheating, hyperthermia, is just as dangerous, maybe even more insidious. It cranks up their metabolism. When their metabolism speeds up, they burn through oxygen and glucose like crazy. For a baby already struggling to breathe and low on energy stores, this can tip them over into respiratory failure or severe hypoglycemia. Plus, being too warm makes them lose a ton of water through their skin and breathing insensible water loss. Their little kidneys can't keep up, leading to dehydration really fast.
Wow. Okay, so that really highlights the nursing priorities. Beyond breathing support, what are the key things?
Thermoregulation has to be precise. We use radiant warmers, or those double-walled incubators. Temperature checks are frequent axillary temp, skin probe monitoring, and weaning them to an open crib is a slow, careful process. They have to prove they can hold their own temp first. And pain management is key too. Even small things, like heel sticks for blood draws or suctioning, cause stress. That stress burns oxygen and glucose they just don't have to spare.
Right. So for those minor procedures, what's the best non-drug approach to manage that pain?
The evidence points strongly to a combination. Giving a tiny bit of oral sucrose sugar water, basically paired with non-nutritive sucking, like a pacifier, it seems to trigger their natural pain relief system. We combine that with containment, often called facilitated teching. Gently holding their arms and legs flexed close to their body provides boundaries, kind of like being back in the womb. It's very soothing. Hashtag PB, late preterm infants, 3407 to 3667 weeks.
Okay, let's shift gears slightly to the late preterm infant. This group, born between 34 and just under 37 weeks. They're tricky, aren't they? They can look almost full term.
They are incredibly tricky. That's the danger, their deceptive appearance. They might weigh 5, even 6 pounds, look pink and pretty healthy. So staff, and especially parents, might treat them like a term baby. But physiologically, metabolically, they are still immature. They don't have the reserves. That's why they have higher rates of ending up back in the hospital or needing NICU care after going home. They seem fine, then they crash.
What are the main risks for this group, stemming from that hidden immaturity?
You can think of the big three: hypothermia, hypoglycemia, and jaundice. They're all linked to their limited energy stores and immature liver function. Plus, they often have real trouble with feeding because their coordination isn't quite there yet. And their immune system isn't fully developed either, so higher infection risk.
Let's focus on those feeding issues. They look like they should eat well, but they just tire out.
Exactly. That suck, swallow, breathe pattern isn't automatic for them yet. They might latch okay at first, but their suck is weak. They get tired really fast, often fall asleep halfway through a feed, and don't actually transfer much milk.
Hmm.
This effort burns precious calories and uses up their already low glucose stores, putting them right at risk for hypoglycemia. So, nursing care has to include frequent feeds every 2 to 3 hours around the clock and really careful assessment of how much they're actually eating. We often need to supplement or add fortifiers to make sure they get enough calories.
And even if they seem stable, they need closer temperature monitoring than a term baby. What's the protocol there?
Absolutely. We check their temperature every 3 to 4 hours for at least the first 24 hours. And parent teaching is critical here. Parents need to understand their baby needs one more layer of clothing than an adult would wear to be comfortable. Keep them away from drafts. The goal is to prevent that temperature drop that triggers all that metabolic stress.
And there's a strict checklist before they can even think about going home, right?
Yeah.
For safety.
It's non-negotiable. The criteria are strict because we have to be sure they're stable. They have to stay in the hospital for at least 48 hours, minimum. Before discharge, they must show they can feed effectively, consistently, and maintain stable vital signs for at least 12 hours straight. And bilirubin screening is a must because their jaundice risk is high. And very importantly, we have to do the car seat challenge before they leave.
Right, explain that. Why is that specific safety test needed for preterm and late preterm babies?
It's about their anatomy and muscle tone. Late preterms often have weaker neck and torso muscles. Their heads are proportionally large, so when they're semi-reclined in a standard car seat, their head can slump forward, kinking off their airway. This can cause their oxygen levels to drop or their heart rate to slow down, positional apnea or bradycardia. The car seat challenge involves monitoring them in their own car seat for 90 to 120 minutes, watching their breathing, heart rate, and oxygen saturation. If they have any significant dips, they fail. They might need to go home lying flat in a special car bed instead.
Okay, moving on from prematurity itself. Let's talk about probably the single most common reason any newborn, term or near term, gets admitted to the NICU for breathing trouble: transient tachypnea of the newborn, or PTN.
Right, TTN. It basically means temporary fast breathing. What's happening is a delay in clearing the fluid that's normally in the baby's lungs before birth. During fetal life, the lungs are filled with fluid. Usually, a lot of this gets squeezed out during vaginal birth or absorbed right around delivery time. With TTN, that fluid doesn't clear fast enough through the lungs' lymphatic system. The leftover fluid makes the lungs a bit stiffer, so the baby has to breathe faster and shallower to compensate. That's the tachypnea.
Sometimes called wet lung, right? What
Yeah.
makes a baby more likely to get TTN? You mentioned C-sections.
Yes, cesarean birth is the biggest risk factor. Those babies miss out on that good thoracic squeeze during passage through the birth canal, which helps push fluid out. Other things that increase the risk are being a large baby, macrosomia, multiple births like twins, a really long labor, sometimes a very fast labor, and maternal factors like asthma or if the mom received a lot of sedation. Basically, anything that might interfere with those normal fluid clearing mechanisms.
What does it look like clinically? What are the signs you'd see?
The main sign is rapid breathing tachypnea, usually a rate over 60 breaths per minute. This typically starts within the first few hours after birth. You might also see some mild to moderate signs of respiratory distress, maybe some grunting, flaring of the nostrils, sometimes mild retractions like the skin pulling in between the ribs. But the key word is transient. It usually gets better on its own within 24 to 48 hours as the body finally absorbs that extra fluid.
And nursing care is mostly supportive then, keeping them stable while the body does its work.
Exactly, supportive care. We often give them a little extra oxygen, maybe through a hood or nasal cannula. Sometimes, if the breathing work is moderate, they might need CPAP for a bit, but a really critical part of the nursing care is managing feeding. A baby breathing 70, 80 times a minute just cannot safely coordinate sucking, swallowing, and breathing. Trying to bottle or breastfeed them when they're breathing that fast carries a really high risk of aspiration fluid going into the lungs. Plus, the effort just burns too many calories. So we often use gavage feedings, feeding them through a small tube that goes into their stomach until their respiratory rate comes down to a safer level, usually below 60. This conserves their energy, keeps them hydrated, and avoids aspiration.
Okay, here's a key point for our BSN students. A term baby starts breathing fast, grunting a bit, maybe an hour after birth. How do you, as the nurse, start thinking about differentiating PTN from something more serious like RDS, which we talked about with preemies, or even an infection like sepsis, just based on how the baby looks and acts initially?
That's a critical thinking point, absolutely. The initial picture can look similar, right? Fast breathing, some distress signs, but the trajectory is often the biggest clue. TTN usually gets better fairly quickly, often within that first day or two, and typically only needs fairly low levels of oxygen. RDS, which is about surfactant deficiency, tends to get worse over the first 48 hours or so. Those babies usually need more significant, often escalating respiratory support. A chest x-ray can help too. TTN often shows fluid lines in the lung fissures, kind of streaky looking. RDS typically has more of a hazy ground glass appearance because the air sacs are collapsed. But, and this is crucial, if there were any signs of distress at birth requiring resuscitation, or if the mom had risk factors like her water being broken for a long time, you have to consider sepsis. In that case, you'd expect a full workup, blood cultures, maybe a spinal tap, regardless of what the initial chest x-ray looks like. You can't afford to miss sepsis.
Okay, let's shift to the metabolic side of things. Two really big areas requiring super sharp nursing vigilance: hyperbilirubinemia jaundice and caring for the infant of a diabetic mother, the IDM, hashtag A. Hyperbilirubinemia, pathologic jaundice.
Right. Jaundice is super common. Most babies get a little bit yellow after the first day. That's physiologic jaundice. It's just the immature liver catching up with breaking down old red blood cells. Normal adaptation. But pathologic jaundice is different. It signals an underlying problem. It shows up earlier, the bilirubin level climbs faster and higher, or it stays elevated longer than you'd expect.
And this is where timing is everything, isn't it? There's a critical time window nurses need to know.
Absolutely. Here's a hard and fast rule. Jaundice appearing within the first 24 hours of life is always considered abnormal, potentially serious, and must be reported immediately. That early onset strongly suggests there's some rapid excessive breakdown of red blood cells happening, hemolysis. Catching it early is the key to preventing brain damage.
Let's talk about that damage. What actually happens if bilirubin gets too high, and what are the terms students need to know?
The danger stuff is the unconjugated bilirubin. It's fat soluble, meaning it can cross the blood-brain barrier. If levels get dangerously high, it enters the brain tissue. Initially, this causes acute brain dysfunction. We call that acute bilirubin encephalopathy. Symptoms might be lethargy, poor feeding, maybe irritability, or a high-pitched cry. If it's not treated quickly and the bilirubin deposits permanently in certain parts of the brain, especially the basal ganglia, that causes kernicterus. Kernicterus is permanent brain damage. It can lead to things like cerebral palsy, hearing loss, developmental delays, devastating lifelong consequences, which is why early detection is so critical.
So what are the most common reasons for this rapid pathologic bilirubin rise? Usually blood type issues.
Yeah, most commonly it's due to RH incompatibility or ABO incompatibility between the mother and baby. This leads to hemolytic disease of the newborn. For example, if mom is type O blood and baby is type AOB, mom might have antibodies against A or B blood cells. Those antibodies can cross the placenta, attach to the baby's red blood cells, and basically mark them for destruction. This massive ongoing destruction of red blood cells releases a huge load of bilirubin, way more than the baby's immature liver can handle.
And how do we confirm that this destruction is actually happening? There's a specific test, right?
Yes, the direct Coombs test, or D8 direct antiglobulin test. We do this test on the baby's blood. A positive direct Coombs test tells us that maternal antibodies are stuck to the surface of the baby's red blood cells. It confirms that hemolysis is actively occurring. This is a really important finding because it flags the baby as high risk. We know the bilirubin is going to keep rising because the red cells are still being destroyed.
And the main treatment for high bilirubin is phototherapy. Those blue lights. How exactly does the light work? What's it doing?
It's pretty clever, actually. The specific wavelength of blue light changes the shape of the unconjugated bilirubin molecule in the skin. This process, called photosummarization, converts the fat-soluble bilirubin into a water-soluble form, mainly something called lumorubin. This water-soluble form doesn't need to be processed by the liver anymore. It can be excreted directly by the baby in their urine and stool. So the goal is just to get as much skin exposed to that light as possible.
Okay, so if the goal is maximum skin exposure under the lights, what are the absolute must-do nursing actions?
3 key things. 1, protect the eyes. You must use eye patches or shields, making sure they fit snugly but don't block the nose, to prevent retinal damage from the intense light. 2, maximize skin exposure. Baby should be wearing only a diaper, and you need to turn the baby frequently, usually every 2 hours or so, to get different areas exposed to the light. 3, hydration, hydration, hydration. Phototherapy increases water loss through the skin and also speeds up bowel movements. So we need to make sure the baby is getting enough fluids, often increasing their intake by about 25%, usually through more frequent feeding. We also track their output really closely. You actually want to see frequent, loose, often greenish stools. That green color is the bilirubin being excreted. It's a good sign that therapy is working. If the stools slow down or urine output drops, that's a red flag for dehydration. Be infant of a diabetic mother, IDM.
All right, let's switch gears to the infant of a diabetic mother, or IDM. Maternal diabetes creates a whole different set of risks, and it kind of depends on when the mom's sugar control was off, right?
Exactly. If the mother had poor glucose control really early in pregnancy, first trimester, that significantly bumps up the risk for major congenital anomalies, heart defects, skeletal problems. But if the high blood sugar happens later in pregnancy, the fetus responds by making extra insulin. In the fetus, insulin acts like a powerful growth hormone. This leads to macrosomia. The baby grows really large for their gestational age. These IDMs often have a classic look. They can be quite red, plump, kind of chubby with round faces because of all the extra fat and glycogen they've stored up.
They look big and healthy, but they're actually quite fragile metabolically. And the biggest, most immediate risk is low blood sugar.
Yes, hypoglycemia is the #1 immediate problem. Think about it. In the womb, the baby's pancreas was working overtime, pumping out tons of insulin to handle the high sugar levels coming from the mom. The second that umbilical cord is cut, that high glucose supply from mom just stops. Abruptly. But the baby's pancreas doesn't get the memo right away. It keeps churning out high levels of insulin. All that insulin rapidly drives the baby's blood sugar down, sometimes dangerously low. Low glucose can cause brain injury or seizures.
How does that low sugar show up? What are the signs a nurse needs to watch for, especially since they might look like a big, robust baby?
The signs can be really subtle, which is why you have to be looking for them. Things like jitteriness or tremors, not full seizures usually, but like a shaky feeling. Poor muscle tone, kind of floppy, sometimes rapid breathing because their body is stressed. They might have trouble maintaining their temperature, feel cool to the touch. Lethargy, being hard to wake up, or having a really poor, weak suck for feeding. Because they look so big, it's easy to miss these subtle signs unless you're specifically assessing for them.
Which leads to specific protocols. What's the absolute critical nursing action for every IDM?
You absolutely must check their blood sugar soon after birth, ideally within the first 30 to 60 minutes. And then you need to repeat those checks frequently. Usually it's every hour for the first 4 to 6 hours, or until the levels are stable and in a safe range. Any glucose level below that critical threshold, typically around 40 to 45 milligrams per deciliter, needs to be reported immediately. And the main intervention is early feeding. We push for breastfeeding or formula within the first hour of life, get some glucose into them before their own insulin drives their sugar down too low. If feeding isn't enough or their sugar is critically low, we might use buccal dextrose gel or even start an IV with dextrose. And keeping them warm is vital too. Cold stress just makes them burn through glucose even faster. Okay, we need to talk about infection. Sepsis in a newborn it's subtle and incredibly dangerous. Their immune system is just not fully developed. They don't have the mature infection-fighting cells or the antibodies they need, making them extremely vulnerable. Things can go downhill very, very fast.
And we categorize sepsis based on when it starts, right? Early versus late onset.
Correct. Early onset sepsis happens within the first 72 hours, the first 3 days of life. It's usually acquired from the mother during labor or delivery. Risk factors would be things like the mother's water being broken for a long time, say over 18 hours, prolonged rupture of membranes, mom having a fever during labor, or if the mom is known to carry group B strep, GBS, or had another infection. Late onset sepsis occurs after that first week. It's more often picked up from the environment, maybe the hospital, or sometimes related to invasive lines or procedures.
What are those early warning signs? We're always taught that newborns don't necessarily show infection like adults do with a high fever and all that.
That's exactly the challenge. The signs are notoriously subtle and nonspecific. Forget looking for a high fever as your main sign. Often, newborns with sepsis show temperature instability, which frequently means hypothermia. Their temperature drops below normal, like under 97.7 F or 36.5 C. Being cold is often a more ominous sign than being hot in a newborn. Other things to watch for are breathing problems, maybe apnea again or grunting. Poor feeding is a big one, refusing to eat or feeding weakly. Lethargy, being floppy or unresponsive. Or sometimes just irritability, being fussy and inconsolable. Honestly, sometimes the only sign is the parent saying something's not right, or the nurse just getting a feeling that the baby is not acting right. You have to trust that gut feeling and investigate any change.
So if a nurse even suspects infection, what happens next? And thinking prevention, what's the single most impactful thing we can do?
Suspicion alone triggers immediate action. You notify the healthcare provider right away. You anticipate orders for a full sepsis workup, blood cultures, a complete blood count, CBC, with differential, maybe C-reactive protein, CRP, and potentially a lumbar puncture to check the spinal fluid. And you get ready to administer broad-spectrum IV antibiotics immediately, often before the culture results are even back. Time is absolutely critical with neonatal sepsis, but prevention, day in, day out.
Yeah.
This is where nursing makes a massive difference. And the number one thing, hand hygiene. It sounds simple, almost too simple, but it is unequivocally the single most effective way to prevent the spread of infection in the nursery.
Wow. Head and shoulders above everything else.
Absolutely. Strict, consistent hand hygiene washing or using alcohol-based rub before and after touching every single baby by every single person. Staff, parents, visitors, it has to be drilled in and practiced religiously. Beyond that, obviously, meticulous care for any IV lines or catheters, using sterile technique for procedures, keeping equipment clean, but hand hygiene is the cornerstone.
Okay, finally, let's tackle a really complex and often challenging area. Caring for infants withdrawing from prenatal substance exposure, primarily opioids, neonatal abstinence syndrome, or NAS.
NAS is basically a group of withdrawal symptoms that happen when a baby who is exposed to certain drugs in utero is suddenly cut off from that supply at birth. The timing and severity depend a lot on the drug, what it was, how much the mother used, and when her last dose was before delivery. Symptoms usually start to show up within the first 24 to 72 hours, but for some longer-acting drugs like methadone or buprenorphine, the withdrawal might be delayed, sometimes not peaking for a week or even up to 2 weeks.
What are those common symptoms? What does withdrawal look like in a newborn?
It stems from their central nervous system being hypersensitive, overstimulated. So neurologically, you see things like extreme irritability. They're often impossible to console. They have tremors, sometimes quite severe shaking. Increased muscle tone, they feel stiff or rigid. And that classic high-pitched, excessive shrieking cry is very characteristic. Autonomic signs are common too, things like sweating, sneezing, yawning excessively, maybe temperature instability again. And GI symptoms are a huge part of it. They often have frantic sucking but poor feeding, frequent vomiting, sometimes projectile, and loose, watery stools or diarrhea. This puts them at high risk for dehydration and significant skin breakdown in the diaper area. Plus, all this agitation burns a massive amount of calories.
It sounds incredibly volatile. There must be a structured way to assess them, right?
Yeah.
To track how severe it is and guide treatment.
Yes, we use a standardized scoring tool, most commonly the Finnegan Neonatal Abstinence Scoring System, or a modified version. The nurse systematically assesses and scores the baby based on specific signs and symptoms, the intensity of crying, sleep patterns, tremors, muscle tone, feeding behavior, vomiting, stools, etc. This is usually done every 3 to 4 hours. The score helps us quantify the severity of withdrawal. If the scores stay consistently low, below a certain threshold, often around 8, we focus on non-pharmacologic comfort measures. If the scores consistently run high, indicating significant withdrawal that's disrupting feeding and sleep, that's the trigger to cite medication, usually an opioid like morphine or methadone, which is then carefully tapered based on the scores. The score provides the objective data to guide that treatment.
You mentioned the feeding. It sounds like a real paradox. These seem desperately hungry but can't eat properly.
It is a major challenge. They root around frantically, they might latch intensely, but that CNS overstimulation just wrecks their coordination. They can't synchronize the suck, swallow, breathe pattern effectively, so they gag, choke, maybe aspirate and tire out very quickly, often taking in very little despite looking like they're trying so hard. It's frustrating for everyone involved.
So given all that agitation, the most critical nursing intervention seems to be about managing their environment.
100%. The absolute key is to keep stimulation to a minimum. Noise, bright lights, lots of handling, all of it makes withdrawal symptoms worse and drives up their scores, potentially increasing their need for medication. We need to create a calm, quiet, low-lit environment. We cluster our care, do assessments, diaper changes, vitals all at once, then let the baby rest undisturbed for as long as possible. Limit visitors. We use comfort measures like swaddling tightly. That containment helps reduce the tremors and startling. Hold them snugly, rock them gently. Use slow, deliberate movements when handling them. For feeding, we often try small, frequent feeds. Sometimes special nipples help. Because they burn so many calories, they might need a higher calorie formula. If they just can't feed safely by mouth because they're too agitated or uncoordinated, we might need to use gavage feeding temporarily.
And lastly, supporting the parents through this. It has to be done with empathy, right? Avoiding judgment.
Absolutely critical. It can be a very sensitive, emotionally charged situation for families. Our role as nurses is to be non-judgmental, focus on the baby's needs, and provide support. It's so important to educate parents that the baby's behavior, the crying, the irritability, the difficulty being consoled, it's withdrawal. It's a physiological response. It is not the baby rejecting them. We need to teach them the same comfort measures we're using, the swaddling, the quiet holding, minimizing stimulation so they feel empowered to care for their baby and start building that bond, even when it's really challenging. #tag 70. Conclusion and final thought. We've covered a lot of complex ground here with high-risk newborns. But if you boil it down, so much of this care comes back to really consistent, quiet vigilance. Whether it's TTN, jaundice, and IDM's blood sugar and NAS withdrawal, those core nursing skills are the same. Meticulous temperature control, knowing how to provide gentle airway support if needed, that obsessive hand hygiene we talked about, and clear, compassionate parent education. It's about applying those fundamentals, trusting your assessment of the subtle changes, and acting promptly. That's what turns potential crises into managed situations.
Absolutely. Trust the basics. As a generalist nurse, maybe new to newborns, your ability to nail those fundamental steps, the hourly glucose check on the IDM, pushing fluids for the jaundice baby under lights, recognizing sepsis early, promoting that low-stim environment for NAS, that's what makes the difference. You're the coordinator, the teacher, the first line of defense. Always remember to explain the why behind the care to families and bring them into the plan. So we've talked a lot about the challenges, especially with preterm infants. We know managing their fluid balance is critical, and that tracking weight alongside intake and output, or I&O, is key. Here's a final thought to take with you, something to mull over. If tracking I&O is so vital for monitoring fluid status in these very fragile preemies, what single factor makes getting an accurate I&O so uniquely difficult in this specific population? and thinking ahead, what advanced approach might nurses need to use to overcome that challenge?
Yeah, think about that incredibly thin, permeable skin we discussed and their immature kidney function. The big challenge is accounting for the massive amount of fluid they lose just through their skin, that insensible water loss. You can't measure that in a wet diaper. So mitigating that often requires really strict humidity control in their incubator environment to reduce evaporation from the skin. And for accurate output, you often have to resort to weighing diapers, weighing the dry diaper, then weighing the wet one, and calculating the difference to estimate urine output precisely. You also rely heavily on daily weights as the ultimate indicator of overall fluid balance, not just the INO numbers alone.
A complex challenge for a complex population really makes you think about the details. Thanks for diving deep with us today.